Then the first case is a patient, a 35-year-old female with a history of MEN1 that presented with gastritis and abdominal distension, status post-open enucleation of multiple gastrinomas. Her past medical history was the typical history of MEN1 with diabetes mellitus, also and a gastric carcinoid and cholelithiasis. She had a variety of surgeries, again consistent with MEN1, including transphenoidal hypophysectomy, 3.5 gland parathyroidectomy, enucleation, as I said, of 4 pancreatic gastrinomas, and endoscopic removal of a gastric carcinoid. She was adopted. She has a biological sister, which was negative for menin. She was on the medications carbergolene as well as octreotide acetate. The workup demonstrated a mildly elevated gastrin, but a significantly elevated pancreatic polypeptide, and the EUS showed several hypoechoic pancreatic masses distributed through the pancreatic parenchyma. They counted up to 8. On the octreoscan scan, you had some in the head, other ones in the neck of the pancreas, and again, these are the ones on the head. This is the octreoscan scan, multiple lesions, and there was some in the body as well as in the tail. They counted a total of 8, several neuroendocrine tumors. Then, what would the panelists do? And the questions are there. Observation with increase of octreotide dose, enucleations of lesions that were more than 2 centimeters, enucleations of lesions that were more than 1 centimeter, or total pancreatectomy. Then we're going to start from Professor Kwandu. A, B, C, or D?
You know, you hate to do total pancreatectomy, but you may be out of option in her. I would like to see the CT scan to see where all the lesions are. In general, for MEN1 patients, the thing that killed them will be the non-functioning pancreatic neuroendocrine cancers. And she looks like she had big tumor in the head and some tumor in the tail. And I don't know whether it's possible to save any almost normal-looking pancreas in the middle, but I think you are in a bit of trouble here because you know, especially if they're larger than 2 centimeters, you really need to be thinking about removing it. And in somebody with MEN1, I don't know how else you're going to take care of this.
Professor Inapnet?
Well, I think there needs to be an option E. First of all, I'd like to know more about the symptomatology of the patient. I mean, you have a biochemical marker that is high, but is the patient actually having voluminous electrolyte-riddled diarrhea, for example, that's impacting quality of life? So that's going to impact your decision making, because if the patient has an endocrinopathy, a functional endocrinopathy from the MEN1, that's going to impact your management, as opposed to if these are non-functioning and that's just an incidental finding of, you know, it's not contributing to symptomatology. I think if it were functioning, I would favor more of a subtotal pancreatectomy and then a more conservative approach to the head, probably either directed by intraoperative or more likely postoperative directed therapy to the head. You can do an EUS directed alcohol ablation of these lesions, understanding that you may need to come in and do a salvage total pancreatectomy in the patient, but I think that should be a last option for this patient. And that's what I would do. I probably would do a subtotal pancreatectomy and address the head separately, or a total pancreatectomy if the patient really is riddled by symptomatology, but I would do that as a last-ditch effort.
Okay, then we have one total pancreatectomy, one subtotal pancreatectomy, and we'll see what happens on the head. Okay.
It's a similar opinion. Actually, it is very hard to decide this treatment the method in patient multiple this endocrine tumor, especially in patient with MEN1. We need is more data, this information about this medical responsiveness to medication and the interval change of this pancreas mass. If the pancreas mass is increased, I prefer total pancreatectomy in this patient. If not, I will try to do is the conservative the management.
Then at this point, they have been following this patient for a while because she had had prior enucleation of 4 gastrinomas. Then this had been growing or had been becoming more evident because some of them were very small. Then total pancreatectomy or subtotal pancreatectomy, you have to make a decision, or observation.
If there's no responses medication, yeah, I will do total pancreatectomy.
Okay.
Similar.
Professor
So,
Kwon Jin Kim?
yeah. Personally, the patient is relatively young, so I'd like to do a total pancreatectomy to avoid further operation.
Okay. We have 3 total pancreatectomies, 1 subtotal. Professor
Yeah,
Mukan?
I would like to recommend total pancreatectomy because in spite of the previous effort to preserve the pancreas by 4 times of 4 enucleation, but these cases suggest that the recurrence cases, in addition, the gastrinoma may be related to the malignant properties. So in these cases, I think she needs a total pancreatectomy.
Good. Then the majority of the panel says total pancreatectomy, and that was our thought. Professor Kwandu?
Just for historical purpose, there's an option that was a standard option for MEN1 patients called the Thompson procedure, which is a distal pancreatectomy and enucleation of anything larger than, I think, 2 centimeters from the head of the pancreas, and that was a standard procedure for a long time.
Okay. We decided this was a 35-year-old patient. She had already had 4 enucleations, as Professor Kang had said, and we proceeded with a total pancreatectomy. Our pathology report, they had 33 tumors in the pancreas, 32 in the stomach, 1 in the duodenum, ranging from 0.4 to 2.4 centimeters, and she already had 3 out of 29 lymph nodes involved with tumor. Margins were negative. There was no lymphovascular invasion or perineural invasion. And of course, with the power of retrospect, probably considering that she already had lymph nodes, this may have been the best choice. Postoperative course, the polypeptides decreased, the gastrin decreased, her symptoms improved, even though, as Dr. Inabnet pointed out, the symptoms were present but weren't quite really severe. Nevertheless, whatever she had did improve. We discussed all of this. Case number 2, another young patient, another MEN. She had a suicidal attempt, and she was admitted to the emergency room, and she was noted to have anemia. And when asked, she had 3 to 4 years of mild lower abdominal discomfort. She had, again, depression, nothing really significant on the history. An ultrasound and CT of the abdomen showed 2 complex multiloculated cystic lesions in the right hepatic lobe. I'm measuring this, the numbers mentioned above, 9 centimeters in larger diameter by 4. Percutaneous biopsy showed a low-grade neuroendocrine tumor with a Ka67 of less than 2%. Then the primary site was unclear. The patient did have symptoms of diarrhea and the low abdominal discomfort, and we did the workup as shown there and a psychiatric consult. This is the MRI that shows multiple lesions on the right side, much more than what the ultrasound had shown. We also had, by MRI, we do a very specific MRI that's diffusion-weighted MRI with a variety of different contrasts, and we found a highlight on a very small area on the duodenum. Other than that, there was no primary. There was, again, as I said, a persistent abnormal enhancement on the duodenum. Then we did upper endoscopy. The patient was status post a Roux-en-Y gastric bypass. Therefore, the upper endoscopy had to be a double balloon enteroscopy, and there were no mass or lesions identified to explain the liver metastasis, even on the endoscopic ultrasound. However, on the double balloon enteroscopy, there was a submucosal lesion on the second part of the duodenum. Biopsies, and you can see it there, was a low-grade neuroendocrine tumor with lymphovascular invasion, which was positive. Then the lesion was marked. Octreotide scan was positive again for the liver. And then what would be the plan? Remember, this patient had a suicidal attempt, and now she has metastatic pancreatic lesion, duodenal lesion, very small, to the liver. We decided to do the psychiatry consult, and the psychiatrist said, well, she's recovered, she doesn't want to die anymore, she wants everything done. Then we thought, well, we're not convinced that that's going to be the case. And I know this is very difficult, but I'm just going to tell you what we did initially, and then we'll open it for discussion. We did a neoadjuvant due to the stage and proximity to some of the vessels on the right side. We treated her with Y90, and all of this was to be treating the tumor as we assess if the patient indeed was going to remain in a psychiatric status that would not recur from the point of view of the suicidal attempts. And also we wanted to see what was the response. We treated her with sandostatin, capecitabine, and the Y90. The two treated liver lesions 10 weeks later after the Y90 had a very positive response to treatment. The larger lesion in the hepatic dome decreased compared to the first MRI, and the smaller lesions significantly changed. And you can see pre and post treatment, there was a significant improvement with Y90, and at least in our institution, Y90 has been used just recently in the last 2-3 years for this type of lesions, and we have been quite successful, and this was brought by our interventional radiologist. Again, you can see the huge change between pre and post. And then now we had a patient that had a metastatic neuroendocrine tumor in the liver with a large lesion that have responded well to therapy, and a primary duodenal neuroendocrine tumor which was quite small on a patient that had a Roux-en-Y gastric bypass. What do you do now? What would you do now? Okay, we're going to start on this side of the table now. Professor Kang?
I think it's very difficult and complex cases, but the patient is very young, and she told us that she's gonna die anymore. So we recommend, in these cases, then we recommended the right hepatectomy and the duodenal mass excision.
Okay, right hepatectomy and duodenal mass excision.
Okay. Patients already tried suicide, and I think the patient is already responsible to therapy, conservative therapy. So, in my opinion, is observation.
We have hepatectomy and local resection of the duodenal tumor versus observation.
As I presented in my presentation, there is a synchronous resection of his primary tumor and metastasis. There is previously it is considered as very dangerous, but recently this development is perioperative management is increased skill. We can do is synchronous resection, liver resection, and primary tumor resection at the same time. If this patient is a young patient, maybe if the patient doesn't have any comorbidity, we can do this right hepatectomy and this duodenal vessel resection for duodenal primary tumor.
Okay.
Thank you for these very easy cases. This is straightforward. This is great. Question, is the patient still morbidly obese?
No, she's not morbidly obese.
Okay. So
And that is a very good
interesting.
question.
I'm treating an MEN1 patient now that had a gastric bypass. It's actually fascinating because we're encountering some of the same challenges. Different patient though. Well, first of all, I'd want a little bit more information on this patient, and I would want to get a gallium-68 dotatate PET scan, which is available only at a handful of institutions around the United States. But the good news is that FDA approval is imminent, and we think by year's end, this peptide will be FDA approved, and this is the most accurate localizing study for neuroendocrine tumors. You can see tumors as small as 3 or 4 millimeters. So I think that would be helpful in preparing this patient. Also, note that the KS67 index is less than 2%, which shows that this is a low-grade neuroendocrine tumor despite the metastases. So this patient is going to possibly live with a disease burden for a long, long time and actually have a favorable outcome, and that needs to be taken into consideration. I think in the interim, you could try some of the other, if you're trying to buy time to wait for imaging, you could try some of the other agents like lanreotide, which has been shown to be a very effective analog for treating these tumors, particularly if the patient is symptomatic. I would favor, from a surgical point of view, keep in mind also that these are often multifocal, so not only do you have something in just the duodenum, but you've got, I don't know, 15 to 20% chance, I believe, of having synchronous disease elsewhere in the GI tract. And you know that the midgut neuroendocrine tumors are more likely to develop the typical carcinoid syndrome. So this patient clearly has the carcinoid syndrome, and you certainly want to run the intestinal tract and make sure that you treat any synchronous disease that's identified at the time of your operation. So I would favor a thorough, if you're going to surgery, a thorough exploration, looking for additional disease, a local resection of the duodenum, and I've seen some beautiful videos of your outstanding technique of this operation. And as for the liver, I'm not a liver surgeon, but I would suppose a resection. These are probably a little bit too big to do RFA or cryo, so I would favor a formal right hepatectomy.
You know, this is not the kind of case I would be doing either, but I think I agree with what Barry said. We have used gallium scan for these patients that light up very nicely. The patient will need to have a right hepatectomy, and I think a local excision will suffice, even though we know this is most likely the source of metastasis. Another thing you would definitely consider would be lymphadenectomy for these patients. Many of these duodenal lesions would have some positive lymph nodes. You're very likely not going to cure this patient, but she will likely live a long, long time.
Thank you. We proceeded a little bit more aggressive even than what you all have discussed. So we presented this patient at our multidisciplinary board, and the advice was because of the, let me go back, with MRI, we do MRI enterography. And we're very heavy weighted in MRI. We have 3 people that does just MRI of the pancreas and liver. And they felt pretty comfortable that the duodenum was the source. We could not do a duodenectomy given the location of the lesion, and also we were concerned about the lymphadenectomy at the same time. Then we did a right hepatectomy first. We did a laparoscopic right hepatectomy. The patient recovered very well, and the pathology showed, as we expected, a metastatic neuroendocrine carcinoma. She did very well from that surgery, recovered without complications. This is the MRI postoperatively 6 weeks later. We extracted the specimen through fan steel incision, and she did well. And then we proceeded with a laparoscopic pancreatoduodenectomy, and because of the potential multifocality and the fact that she had a Roux-en-Y, we did a subtotal gastrectomy on the remnant stomach, and at the same time we did a couple of other things. She recovered very well from the surgery. However, she presented, and this was the pathology, the duodenum did have 2 foci of low-grade neuroendocrine tumor, 2 centimeter and 0.8 centimeter respectively. The 2 centimeter, we were surprised since it had not appeared in it was so subtle in the other studies, and 2 centimeters was reasonable. There were 5 out of 29 regional lymph nodes on the pancreatoduodenectomy specimen. The margins were negative, and there was a PT3N1M1. She did have a pancreatic leak. These patients are, of course, at a much higher risk for leak because the pancreatic parenchyma is normal and the pancreatic duct is small. And we had to keep a drain there for 3 weeks. And then in postoperative number 36, she had a self-limited GI bleeding that we could not find the source. This was presented before. Are we ready for a case 3 or not? Last one.
I was just telling Barry that that's what I guess you would have done.
Actually, for this
I'll
case,
vouch for that. He did say that.
for this case, I'd like to have a comment. Actually, the metastasis occurs very early stage of the tumor. So we think that the primary tumor is big enough, then we think after metastasis. But still there's just some evidence that actually this and the primary tumor is not yet defined, metastasis occur earlier. So I think this is the case. So this metastasis has been occurred earlier than
you
tumors.
would expect.
Yes, I think so. This is the case.
Interesting. Then this is a 1.6 centimeter solid lesion in the body consistent with an insulinoma and one tail large complex cystic lesion in a patient with an MEN1 that was undergoing regular survival. On the MRI, there were 4 lesions. One was large complex cystic lesion on the left adrenal gland that was unexpected. We had a very small lesion, and you can see these are lesions that are difficult to see in other imaging studies, and this is a diffusion-weighted image on the tail of the pancreas that we could see that lesion. Then we had another small lesion in what appeared to be the tail of the adrenal gland. And we had another small lesion in the head of the pancreas, and I don't know if you can see it there clearly. Let me just see if we can see with the, oh. It's not going back, I'm sorry. I cannot move and that was the other lesion. Then let me just go back. We had the complex cystic tail lesion, we had the adrenal lesion, we had a tail lesion 7 millimeters and the 1.5 centimeter body lesion that was not enhancing. Then the 1.5 lesion was different than the tail lesion. The tail lesion was the one that the radiologist thought was most significant. We did an extremely thorough workup that just for time constraints, including endoscopic ultrasound, and we did octoscan, but all of those were basically negative. Then what would you do? Enucleation of the larger body lesion, enucleation of the smaller tail lesion, distal pancreatectomy, enucleation of the body lesion, adrenalectomy, total pancreatectomy and adrenalectomy, and you can use whatever combination you want of answers that are not there.
Okay, I guess I get this one first. So this is a patient that you would do the Thompson procedure for, which is a distal pancreatectomy and enucleation of larger lesion. Now, the traditional Thompsons you do, you remove quite a bit. So in that case, you won't have to enucleate the body lesion. You would have removed the body part already, and in this, you probably don't have to enucleate anything. Regarding the adrenal, about 10% of MEN1 patients will have adrenal lesions. They need to be worked out, but inevitably they are adrenal adenomas. So you could leave it alone. Now, if you take it out while you are there and it take you 5 extra minutes, probably it won't bother me any, but you probably don't have to do it. And then one other thing is that patients with supposedly MEN1 lesions that also have adrenal lesions, you have to be thinking about MEN4, which is a different variation of MEN1 that's recently recognized. And if it's a woman, they can have female tract tumors of various kind also. So.
Interesting.
I would favor a subtotal pancreatectomy, enucleation, what you could do in the head. And if you're not able to safely enucleate, I would stop and then do an EUS-directed alcohol ablation of the head lesion. And we now have done, actually the Mayo in Rochester has reported, I believe, 9 patients, and we've done 6 with very good outcomes, including primary patients with very high-risk surgical candidates with solitary insulinomas that we have ablated because they were too much of an operative risk with good outcomes.
Good.
Actually, this insulinoma in patient with MEN is likely have this multiple. So distal pancreatectomy is not associated high this postoperative morbidity. So I will do this distal pancreatectomy, and maybe this the body lesion can be included in distal pancreatectomy.
Okay.
Personally, there is risk of suspicious business parastosis, so we should consider total pancreatectomy with adrenalectomy.
Actually, I would like to do inoculation of the body and tail lesion and adrenalectomy, but there's no choice among four, so I will go for C, distal pancreatectomy, and inoculation of the body lesion, adrenalectomy. Same with Dr. Yoon.
Thank you. I think we were all more or less thinking the same. Our intention was to proceed with a distal pancreatectomy, kind of a Thompson procedure, but with the variation that was said about trying to get the enucleation of the body lesion. But we went in, did the distal pancreatectomy, but we could not enucleate the larger lesion because it was deep in the parenchyma. Then we converted the distal to a subtotal pancreatectomy and splenectomy, and we did a left adrenalectomy with en-bloc resection of that little retroperitoneal mass. Interestingly enough, there were 7 neuroendocrine neoplasms. That is not surprising for NEN. The largest was though 1 centimeter. The larger lesion that we were concerned on the neck was just 1 centimeter. 8 out of 41 lymph nodes were positive for metastasis. And the adrenal lesion, as Dr. Kwan-Du has said, it was just a cortical adenoma, and we also found an incidental ganglioneuroma, but since we were there, we just took it out as he suggested, with the only exception that it's not just took us 5 more minutes, it took us a little longer than that. The patient recovered uneventfully. I want to thank everybody. I know we are 10 minutes late, but I appreciate you staying here. And one more time, thank you very much to all the faculty of this session and for the great comments. Thank you.